If you want to know if your mom can have end-of-life care at home with intensive care at home while she's on vasopressin, norepinephrine, and epinephrine, dialysis, as well as BiPAP ventilation, stay tuned. I've got news for you. My name is Patrick Hutzel from intensivecareathome.com, and let's read out this email that I had from William about his mom in intensive care. Hi, Patrick. My name is William. I'm trying to fulfill my mother's last wishes to die at home. She's being kept alive by vasopressin, norepinephrine, epinephrine, CRRT dialysis, and she's on non-invasive BiPAP. This all stems from heart failure and sudden heart arrest from an increased milrinone, unknown why it was increased on the day we were speaking of her discharge from the hospital. This suddenly stopped her heart. I received a call 2 hours after conversation discussing her coming home to perform CPR. She was on vasopressin, etc., and then she became stable and was put back on the ventilator to the lower original dose. A week later, they found MRSA infection in her lungs. She battled the infection for 2 weeks. The hospital thought it cleared up. The next day, her body crashed, and they found another pneumonia. That was a week ago. She's no longer stable, except for high doses of the medications, and her acids rise quickly off the CRRT dialysis. Today, her acid levels reached high enough levels to introduce bicarb to lower. She's scared of dying. This was quick. She just wants to be at home when she passes. The problem is hospice will remove all meds and machines and quote unquote comfort her. I'm looking for a way to have CRRT, vasopressors, BiPAP at home, and highly trained staff to set this up in our home. I've heard of this, but no one has helped me out with this yet and wasted a lot of my time. Is this possible to get a home with the meds, equipment, and staff to run? They consider it curative therapy, even though I'm trying to bring her home with awareness of her being there because she is awake. Please give me some ideas or suggestions. All this is so much appreciated. Thank you. Thank you so much, William, for giving such a detailed explanation of your mom's situation. So here's the thing. Could we take your mom home with intensive care at home? Absolutely, yes. However, your situation is very unique because your mom is awake, right? She has curative treatment from what I can see. She's having curative treatment after heart failure with vasopressin, norepinephrine, epinephrine, and CRRT dialysis and the BiPAP, right? So my suggestion here is to wait, right? Let's see if the vasopressin, norepinephrine, epinephrine, and CRRT is working. Let's see if the BiPAP is working, right? And if all of that is working and it's curative, then the talks about end of life and taking away machines will stop anyway. And maybe not all machines and not, maybe the BiPAP and the dialysis cannot be taken away. Maybe not all inotropes and vasopressors can be taken away. But let's wait. Because at the moment, she's in a safe place. And if things improve, then we can look at taking her home. But I do believe at the moment you just need to wait until she's more stable. And you need to wait until things are improving. Now, I fully understand that your mom is scared of dying, right? I get that. But the good news is she's awake. She's on BiPAP, right? When I first read your email, I thought your mom is intubated and can't talk. But because she's on BiPAP and she can talk and she's awake, alert, that's actually a good thing, right? Not many patients that are actively dying are talking and are awake. So, that's not a guarantee that things may not deteriorate, but that's actually a good thing that your mom is awake and talking and can express her wishes. I would wait for a few more days and see whether things are improving, whether the therapy is working. If the therapy is working and inotropes are being weaned, but she still needs the dialysis and she still needs the BiPAP, then absolutely we should be looking at taking her home. But maybe she can be even weaned off the BiPAP. So I do believe at the moment you should stay positive and you should see if that treatment is working. Unfortunately, when someone is critically ill in intensive care, things don't necessarily happen in a hurry. They might happen slowly over time. Improvement in ICU is often like switching on a light with a dimmer instead of switching on a light with a switch, right? So I would be very patient now, see also if the antibiotics are working, right? And CPR and the infection markers are coming down, and maybe kidney markers are coming down, and they can wean the BiPAP, stay positive. Because here's another thing for explanation. Let's just say they can wean the vasopressors and the inotropes down, then they should be able to mobilize your mum. And that will help with her lungs to expand, and that might help with weaning her off the BiPAP. Now, there's no guarantee, of course, but I think you need to hang in there for a few more days. Now, I'm saying this with much confidence because I have worked in critical care nursing for 25 years in 3 different countries, where I worked as a nurse manager for over 5 years. And I've been consulting and advocating for families in intensive care since 2013 on our sister site at intensivecarehotline.com. But we've also been taking clients home with intensive care at home since 2012 and 2013. So, I'm looking at it from both angles. I understand intensive care at home world inside out, and I understand, the intensive care world inside out because I've worked there for a very long time. So, William, I hope that helps and helps you understand what the next steps are. Bit too early, I think. Might come to that point, but hopefully you don't need intensive care at home, right? And if you don't, that's great. And if you do, you know where we are. So, with intensive care at home, we are providing 24-hour critical care nurses at home, and therefore we provide a genuine alternative to a long-term stay in intensive care for ventilation, tracheostomy, home BiPAP, home CPAP, ventilation without tracheostomy, which is what William's mum's situation is today. Ventilation without tracheostomy, tracheostomy without ventilation, home TPN, home IV potassium infusion, home IV magnesium infusions. We're also providing palliative care at home. We're also providing ventilation weaning at home, and we're also providing central line management, PICC line management, as well as Hickman's line management. We're also providing nasogastric tube management and PEG tube management at home. So in William's situation, it might be palliative care, but once again, if you don't need to go home for palliative care, if you can go home for quality of life and not for quality of end of life, that would be the much better option. So let's just wait and see what happens. We're also sending our critical care nurses into the home for emergency department bypass services. We have done so successfully as part of a program at the Western Sydney Local Area Health District, the In Touch program, saving approximately $2,000 per patient that we keep at home instead of going to ED. We're also therefore in a position to cut the cost of an intensive care bed by around 50%. An intensive care bed costs around $5,000 to $6,000 per bed day. Our service costs between $2,500 and $3,000 per bed day. We're freeing up an ICU bed, and we're improving the quality of life for patients and their families. So it's a win-win situation all around. With intensive care at home, we are currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. We are an NDIS approved service provider all around the country. TAC and WorkSafe in Victoria, ICARE New South Wales, NIISQ in Queensland, as well as the Department of Veteran Affairs, DVA, all around Australia. Our clients and we as a provider have also received funding for public hospitals, private health funds, as well as departments of health. We are the only service provider in Australia that has achieved third-party accreditation for intensive care at home nursing in 2024. We've been achieving this level of accreditation since 2012. No other provider has achieved this high level of accreditation in the community in Australia and has created more intellectual property for intensive care at home than we have. And that puts us in a position to employ hundreds of years of critical care nursing experience combined in the community. No other service provider in 2024 employs a higher skill level in the community than we do, which enables us to look after the highest acuity adults and children in the community in Australia. No other provider in Australia can take on a higher acuity safely in the community than we can. And if you're at home already and you're watching this and you realize that you don't have the right level of support, I will give you a very tangible example today. One of our first clients over 10 years ago was a client who was at home on a ventilator with a tracheostomy with a support worker model, 24/7, of course. Support workers cannot keep a patient at home on a ventilator with a tracheostomy. That's like flying the airplane with the cabin crew instead of the pilot, because this guy was at very high risk of dying, and he was going in and out of ICU because support workers simply do not have the skills, the experience and knowledge how to look after a ventilator and the tracheostomy at home. This is an intensive care nursing skill and critical care nursing skill only. It's not even the skill of a general registered. Eventually, this client and the hospital he was going to regularly and the ICU found out about us. We proved our concept there pretty quickly with this client, and we worked with the client and we sent him intensive care nurses 24 hours a day. He never ever went back into ICU ever again with our service, and he was safe. We can do the same for you if you are not safe at home or if you are in a similar predicament, which includes the advocacy that goes along with it to get the relevant funding. We have always successfully advocated for our clients, otherwise we wouldn't be in business. This is also why we're providing level 2 and level 3 NDI support coordination. We have a team of NDI support coordinators and they have a wealth of knowledge. I will put into the written version of this blog an interview that I've done with Amanda Riches, one of our NDI support coordinators. We're also providing TAC case management and WorkSafe case management in Victoria. And if you're an NDI support coordinator or a case manager from another organization watching this, and you're looking for nursing care for your participants, please reach out to us as well. If you're looking for funding for nursing care for your participants and you don't know how to go about it and what evidence to provide, I encourage you to reach out to us as well. We can help you with the right level of advocacy. We also provide NDIS specialist nursing assessments done by critical care nurses with a legal nurse consulting background. And if you are a critical care nurse and you're looking for a career change, we're currently hiring for jobs for critical care nurses in the home in Melbourne, Sydney, Brisbane, in Albury, Wodonga, in Bendigo, in Geelong, and in Warragul in Victoria. If you have worked in critical care nursing for a minimum of 2 years, pediatric ICU ED, and you have already completed a postgraduate critical care nursing qualification, we will be delighted hearing from you. I have a disclaimer though, because we are offering a tailor-made solution for our clients, which includes regular staff. Our clients do want the same staff coming over and over again because they are so vulnerable and so special, and that's why we need regular staff. So if you're looking for agency work where you can come and go, this is not the right fit for you. We're looking for consistency and our clients are looking for consistency. So please only apply with us if you can give us regular and consistent availabilities for shifts and you're really keen on building relationships with us and with our clients. Otherwise, it's not going to work. And if you're an intensive care specialist or an ED specialist, we also want to hear from you. We're currently expanding our medical team as well. We can also help you eliminate your bed blocks in ICU and ED for your long-term patients or for your regularly readmitting patients with our critical care nursing team at home. We're here to help you take the pressure off your ICU and ED beds. And in most cases, you won't even pay for it. Even if you do pay for it, it's much more cost effective than what you're paying for in ICU and ED. And if you're a hospital executive watching this and you have bed blocks in your ICU, ED, respiratory wards, etc., please reach out to us as well. We can help you there fast. And if you're in the US or in the UK and you're watching this and you need help, we want to hear from you as well. We can help you there privately. Once again, our website is intensivecareathome.com. Call us on one of the numbers on the top of our website or send us an email to info@intensivecareathome.com. And if you like my videos, subscribe to my YouTube channel for regular updates for families with intensive care at home and intensive care. Click the like button, click the notification bell, share this video with your friends and families, and leave your comments below and what you want to see next. What do you think about today's topic and what insights you have from this video? Thank you so much for watching. This is Patrick Hutzel from intensivecareathome.com, and I will talk to you in a few days. Take care.